Good afternoon, everyone. Welcome to June's Community Conversation with CFHA. I'm your host, Stacey Augusto. I'm a licensed clinical social worker in Illinois and happy to serve as a facilitator and just general kind of helper and assistant for this conversation today. If you feel so inclined, please flip those cameras on if you would like to participate in the conversation. These are really meant for your benefit. We got a strong interest via email and listserv to connect with other women's health professionals to talk about integrated care in general settings, in specialty women's care settings. And so we brought on 3 experts for you to discuss that and answer your questions. So really excited today, and our team is excited to share their knowledge with you. But please be thinking of questions or topics that you really wanted to dive into today. That really helps to move the conversation forward. You can put things in the chat, of course, and I'll monitor that and serve those up for the team. But I'll turn it over to our 3 super participants and experts today. We have Dr. Helen Coons, Dr. Bethany Ashby, and Dr. Jennifer Thomas here with us today. So I'll turn it over if which of the 3 would like to introduce yourself and kind of talk a little bit about your work.
Go for it, Dr. Thomas.
Hi guys, I'm Jen Thomas, family medicine, addiction medicine physician, and co-medical director at CFHA. So we're pulling together because you guys responded. We put out a listserv message on Gaggle and just said who's doing integrated care in specialty settings, OB/GYN settings, cardio, nephrology, oncology, you name it. And a lot of you guys responded. So we thought it would be great to pull together today and talk about what you're seeing in your shop and what challenges you're having, and really hoping to connect you all as a group, a nucleus of members, so we can grow those connections and keep developing programming and a community of support. So that's me, and would love to pass it off to Dr. Coons.
Well, thanks. And thanks, Stacey and Hannah from CFHA for facilitating this. And we're really delighted that everyone's joined us. I'm Dr. Helen Coons. I'm a board certified clinical health psychologist with a lifelong specialty in women's health and mental health, and have a particular passion for providing our services in integrated both women's primary and specialty settings. So my career has focused both on direct service over, I just realized, since roughly late 1990 or 2000, over the years, I've been integrated in women's primary care and women's multi-specialty settings, OB/GYN settings, MFM, infertility, PCOS, pelvic pain, sexual medicine, and both surgical and medical oncology for breast cancer. So I'm probably missing a few, but in terms of providing direct service, I've so enjoyed providing care in those in varied women's primary and specialty settings. Also have the privilege of having spent many of my years helping institutions with program development to integrate the range of behavioral health services in OB/GYN, in breast, in menopause, and sexual medicine, and other settings, pelvic floor, PCOS, as well as system consultations on how to do it. And some of you know, recently I had the privilege of editing with a physician at Cherokee Health Systems an entire edition of clinical OB/GYN on integration in women's health. So really excited to be with you here and recognize some familiar names, and we'll have a rich conversation. Dr. Ashby.
Hi, everybody. Glad to be here. My name is Bethany Ashby. I'm a clinical psychologist at the University of Colorado, and I direct 3 integrated behavioral health programs in OB/GYN and pediatrics. So my focus is really perinatal, and then I have a special interest in adolescent, pregnant, and parenting. And so I lead a clinic specifically in OB/GYN, specifically for pregnant and parenting teens.
Great. Thank you. Thanks for introducing yourselves. Is there anything that anyone wanted to make sure that we touch on today? Any sort of burning questions or reasons you joined the call? Again, you can put those in the chat. But I do have a question. My specialty is substance use. and integrated care in FQHC settings. And as we were sort of exchanging emails to prep for this conversation, there was a clarification around primary women's OBGYN settings and specialty settings. And I, not having a lot of knowledge and experience, would love just a little bit of clarification on what those look like, the differences.
So why don't I start and you can all jump in. So if you look at IOM definitions, which certainly can change, we think of primary care, right, as internal medicine, family medicine, pediatrics. I think there's a lot of senior primary care as well, which as a set that look like a specialty, but it's really primary care. And so OBGYN is also considered in the traditional IOM definitions a primary care setting. So general obstetrics, general GYN. However, we just listed examples of a whole long list of specialty women's primary care, which would be things like PCOS clinics, menopause clinics, sexual medicine clinic, surgical and breast oncology, radiation oncology, GYN onc. Those are specialty women's health settings. There's women's cardiology in some major medical centers. Not many, but there's a few. And those are examples of specialty women's health. There's also, in some places, multi-specialty women's primary care, but they may have, for example, an infertility specialist or a breast surgeon, and they really do mostly primary care, but have specialty along the way. So those are kind of hybrid. I don't know if Dr. Ashby or Dr. Thomas want to add to that, but traditional general OB and GYN services are primary care.
You think now it's perfect.
So what you're saying is everyone should be able to and know how to treat women. Got it. Thank you. That's great. So Martha in the chat is saying that they have a robust IVH collaborative care program in primary care, but interested in starting an integrated behavioral health program in their OBGYN department too. They have limited resources, so I'm interested in seeing the best place to start. Thank you for your question. So Dr. Thomas or Dr. Ashby, do you want to riff on that?
We'll talk about that. I think, if we're not thinking about funding, because that's always the biggest piece, but I think if you're not thinking about funding and just thinking about how to start, I think really getting a sense from your medical colleagues about what they're most interested in, because I think a lot of times we as mental health providers have ideas about how we can best serve patients in integrated settings. And I think our medical colleagues often have a very different idea. So I think really just starting with collaboration, provider champion, all of those kinds of things that we know to do. I know in our programs, we looked for grant funding in order to support the work that we do, because it's very hard to sustain the programs without grant funding. So we do always bill, but there's challenges with reimbursement.
Yeah, I would agree. I think a good place to start is, within your health system, meeting with the folks doing IBH and COCM. So whether it's an internal medicine or family medicine department that's already pioneering that in the primary care space, sitting down with those folks and talking through what's working and what's not. For this population, you might have a fairly young, healthy female that doesn't regularly see a family medicine provider for an annual physical, but maybe they see their gynae every year, and that gynae does primary care. They're ordering their lipid panel, they're screening them for depression, treating depression, anxiety. So I think just kind of clarifying, like, who are we hoping to help? And if there's overlap, between, they already do have a PCP versus a gynecologist, kind of just talking through those nuances is a really good thing to kind of within your own system, know who's who and who's already doing what, so you can maybe build on that.
Yeah, I really agree with my colleagues, and I would add to that when you approach the director, you want to not just have your medical director, but you also want to have your senior administrators there. It's you need to have system support, and you want to go in with a very succinct business plan. And it may not be the first conversation, but you want to be prepared to have kind of some clear bullets about why is this a benefit? Who gets what? And those benefits are not only to patient outcomes and patient satisfaction, but we have data on provider satisfaction and probably some cost offset data. Not as much as we'd like, but some. But you want to be prepared with what's the rationale, and you want to very succinctly, using the language of your leaders, not the language of our professions, make the case. And it's helpful at some point to write an executive summary, 1 page. And what does this bring to the practice for whom, not only patients and providers and systems, but how does it distinguish you in the market? Where are there gaps that you're able to meet? And how would you get started?
So Martha, please feel free to come off mute if you feel comfortable, if that's helpful, or if you have further questions.
Sure. No, thank you. That was very helpful. I'm the social work supervisor for collaborative care, as well as a lot of the other social work departments. So I'm very familiar with our collaborative care program. And yeah, we've been doing the screenings for depression and anxiety in the Ob and Gyn clinic for a long time, with our social worker intervening for anybody with a score over 10. But we would love to be able to just start providing therapy services as well to help kind of address the behavioral health issues. So no, I appreciate that. I need to just get the business plan going, and you're right, put it in the language of the leaders, not our language. Thank you for the feedback.
Good luck. Keep us posted, and
Thank you.
And I suspect we'd be happy to work with you to expand.
I appreciate that. Yeah, I'm super passionate about this. So there's just such a large area where we're not capturing patients and meeting their needs where they are. So.
And Martha, do you have a physician champion at the OBGYN practice that could be your liaison to help with their providers for their buy-in? We found that very helpful.
Yeah.
And cheerleader that would kind of get the ball rolling for here's why, as gynecologists, we should care about IVH and do COCM. That might be a good place to start too.
Yeah, I appreciated that feedback. We will definitely identify somebody. There's probably a bunch of people who would push each other out of the way to be the champion on this. So we'll have to see, who's going to Rochambeau for it.
Yeah, absolutely. And then tailoring, the why, like crafting the why should I care? Why should I do this as a gynecologist? It's going to be different for every audience member. But I would guess from my hospital system experience, the gynecologist would say, well, it's challenging when I can't just refer out, if they're not interested in treating IVH or psychiatry problems, you might say, well, I would just, refer to a psychiatrist. Not that that necessarily would be the right or best plan, but if you can craft that elevator pitch around like, this is how it helps you, you're adding additional teammates so that you don't have to say, wait 3 months to see a psychiatrist or never get to a therapist because there's no one in your town that takes Medicaid or whatever those barriers might be. Talking about why it's helping to do it in-house in their own gynae clinic might be a way to kind of help them envision a future where integration could help them in their day-to-day flow and make them more efficient, get them out on time, have their patients be healthier and get better quicker with that team-based approach.
Perfect. Thank you. I might be reaching out to you.
So we're talking a little bit about how to kind of generate a business case and interest for integrated care. And I like Michael's comment, which in addition to the provider champion and the business case is using the high scores, right, on the depression screeners, the postpartum screenings that can make the case for you, right? Michael, I'm not sure if you want to say anything else about that, but that was a helpful comment.
Yeah, I mean, yeah, when you were talking about where to start, I wasn't sure whether you're talking about funding or just the general interest, but I think, with those, certainly in our system, the Edinburghs and PHQ-9s are mandated to be done, by our different institutes. And then it's a question of what do we do with them now that we have them? And I would say, we have 2 clinics that are, working in collaborative care model, and OBGYN is our biggest advocates at this point because they're able to get people in very timely within a week or so. And then also do the magic in doing short-term interventions and stuff. So, when you present, I think the OBs who are working with within an episode of care of pregnancy, I think it just makes it very clinically attractive. But of course, it has to, the business case has to be made, and having some seed money to through a grant or if through the organization just to jumpstart it is helpful.
Do you want me to pick up on that, Stacy, about other ways? Sure. So
Sure.
thank you for starting that conversation about funding. So yeah, you do want to look at initial seed money, and that may be at your practice level, at your organizational level, at a system level, and those are important conversations to start early. But you can't stop there. So there are grants. There are sometimes city, federal, and state, state and federal grants. Let me say that differently. There were, with some uncertainty about moving forward, the kinds of the grants that would readily fund integrated behavioral health in any number of women's health settings, especially when they are targeting individuals who face significant barriers to receiving services, and we can readily make the case about improving a range of outcomes. And so whether you're in rural or frontier settings, or you're in inner city settings with populations that need tailored care, there's lots of ways to make the case for local, state, and federal grants. Relatedly, there are foundations whose mission are very aligned with much of the work that we do, and they may have special initiatives that would fund programs. Those grants often don't fund people, but foundation grants, but they sometimes fund other components of integrated initiatives that are extremely helpful. And then also, historically, there's occasionally been some payers who are interested in integrated care and may contribute to the funding portfolio. So one of the ways I think about this is just like you all think about retirement. You want to have a diversified portfolio, and if that's even more true now, of having different funding streams. There are other kinds of grants out there as well that are going to be harder to get, but that won't be forever, and you want to keep your eye on them. There's also collaborations with different kinds of community organizations that are on opportunities. So again, think diversified portfolios with streams coming in through varied ways. It's not just always a traditional staff or faculty position. My colleagues may want to expand, but that's how I think about the pathways to supporting a program, but not just for launching, but to sustain. They say you have to make the case of how you're going to sustain as well. Dr. Ashby or Thomas, do you want to add to that?
Yeah, I think for our group, what we've really looked at is medical outcomes, because that really matters to our OBGYN providers in a different way that mental health outcomes do. So really talking about how treating depression in the perinatal period reduces preterm birth, that is something they are very interested in. And so I think when we tie it to what our medical team is really interested in, they have been more willing to find space for us to sort of make things work because we're impacting the outcomes they care about. And often, they can provide a little bit of money, or even, space is always an issue. But once they think about, oh, this could impact the birth outcomes for my patient, yes, you can use this tiny conference room in this hallway because we don't really use it that often. So I think, as Dr. Coons said, using the language that they use and finding a way that it benefits them specifically and their patients. rather than just a broad, we can treat depression and anxiety. This is really helpful in terms of mental health outcomes, looking at those medical or physical outcomes.
Something that I've done with some success that's a little bit of a different, kind of like a scrappier way of this is like if you're making a business case and looking at funding, right? Very methodical kind of approach. Other approaches that I've tried and would be curious if anyone else has thought about it like this or done this, but sometimes just floating an existing behavioral health consultant into the OB primary care clinic was we just needed a body there. We needed somebody to react to the screeners, and that is a really powerful way to build interest and get a lot of medical provider support, and to test out some things and procedures, right? So you can, I mean, I sort of think about it that way too. As you're sort of building the more methodical case for additional positions, potentially utilizing who you have to support the patients and see what the medical interest is, and what problems come up so that you can sort of get ahead of those and work through those and then build on that, right? Because if everybody's clamoring for the BHC that you float there one day a week, well, suddenly you have 5 people behind you that you maybe didn't have before, or patients that are wanting to talk to that person. So I think that can be really another way to approach it.
I love that.
Stacey, I love that. Oh, please go ahead.
I was just gonna say, ditto, agree. I think it's helpful to give, especially if you're scaling it and expanding, give them a taste, like providers, clinic.
Oh,
Oh,
Doc leaves and talk about those goals and talk about their sleep or their stress. Like that would be awesome. So I love that the word scrappy use. That's great. It's so innovative to like say, what can we do to get buy-in? And you might have to show, you might instead of tell, right? Like experience it. This is what it's like to have additional teammates. And our providers love it. When we had turnover, they're like beating the, drum at the med staff meeting. When are we getting a new BHC? We got to have it. We're not going
Yeah.
back. We can't practice without one. I mean, when you get there, they know they're, not drinking the Kool-Aid, but they've seen the benefit, and that's great. Then you really have true partners.
yes.
yeah, it really speaks to the relational part of this and really being an amazing resource. One of the earliest experience I had, and I think it was probably late 1990 or 9 or 2000, because I remember this, is just being in an integrated setting. And one of the very accomplished, delightful OBGYNs just completely distressed because no one would help her with resources for a patient who was had significant substance use. And I'm like, can you give me 2 minutes? And this is what we do. And 4 minutes later, I come back with a list of 3 top places, and the patient had already left, so I couldn't evaluate her. But I could just see this physician just transition, not about me per se, but oh, wow, when you have someone with our skills standing next to me to collaborate, and it was transformative and went on to be a very long collaborative relationship. And when we can come through like that, it's just it just makes all the difference in the world. They get it in a minute.
Mhm.
And so I want to just speak to those relational moments that are, it is always worth going that extra moment, because it really then sends this very long, very powerful message that we're available and we help and we make a difference. And it helped with the patient, and it helped with this very busy provider's distress as well.
That's awesome. Okay. Any other, I see people looking like they have things they want to share. You can come off mute. We do have something in the chat, just to switch gears a little bit, from Michelle. Michelle, if you're feeling brave or want to share more in working in a women's correctional institute or setting, and sort of a hope and a wish that she can add additional BHCs. If there's anything else you wanted to kind of share, or if anybody else is working in corrections or has experience with that. This is a different setting.
It's such an important primary care setting, even though it's a very specialized setting, and most of us probably on this call aren't trained to work in that setting. But prisons provide an amazing amount of the continuum of women's primary care. You may want to look at the Department of Corrections. I have zero idea what is happening in the department, frankly, so bear with me with my comments. To see if they actually have any focused money. Some of the cities do. In Denver, actually, Dr. Ashby, you might be able to speak with that, but there's some specialty monies that are designed and tailored for correctional institutions. I think I don't know what you're eligible for because there are different levels of forensic settings. But there are monies out there, and I would use the same approach about talking with your leadership, both your clinical and administrative leadership.
I don't have a whole lot of experience either. I mean, we certainly have incarcerated women come for care, but I don't have much experience in that setting.
It's a great CFHA program to actually do a community conversation on our colleagues who provide integrated behavioral health in correctional continuum of correctional settings. You can hear I can't even name them all because it's just not the area of expertise. But we know we have colleagues all over the country who work in varied levels of prison and in forensic settings doing integrated and collaborative care. What a rich conversation that would be.
Absolutely. We'll write that down.
And provide vital services that we don't see, really.
Right. I'm leaving some space here for people.
What are some of the biggest challenges you're all facing right now in your women's health settings, either because you want to launch or you're already in them? We have several very experienced colleagues. I see that Dr. Kruper and Dr. Prescott are on the call as well. What are some of the, or what are some of the innovations and things you're excited about? To put you on the spot.
Happy to jump in. So I'm a health psychologist directly embedded in an academic medical center in an OB/GYN department, and have had the pleasure to be recruiting and growing our team. So we've had a postdoctoral fellow this past year, and we've kind of done some kind of pilot integrated care work directly with our OB/GYN medical team members, as far as her being directly located in the workroom, accessible for same day access for patient care. So she didn't have any, we started off with, she didn't have any other outpatient visits scheduled. So her whole day was open and available for same day add-on care. And there's been challenges. I think it's been great to have this rolled out and be able to kind of do this in a pilot approach within a fellow role to kind of see what works and triage it. But utilization and getting uptake, even though we have a ton of data on the need and the benefits, it's a great example of someone is right there, readily accessible, can see patients with any need. And there's a mix. Either providers are too busy and missing it to bring up with patients. Sometimes patients didn't necessarily want same day or couldn't stay for a same day access. So we ended up kind of morphing and did a mixed template model where she had some scheduled outpatients and then was available for same day add-on consultations. So, I mean, I think that's probably been the biggest surprise that I had in rolling it out, of, being able to kind of put a dedicated individual right there next to them, kind of almost hand holding. For the first few weeks, she was actually doing chart reviews of patients coming into the clinic and putting it on the radar of the medical provider and saying, hey, this patient has these kind of risk factors or these concerns, bring up this service. And so it was pretty kind of surprising that the uptake was still kind of as low as it was.
I am so glad that you brought that up. And I do a lot of work in Illinois with primary care FQHCs. And that story is, you could tell that story about kind of any new service. And it's replicated across settings. So I would love people's thoughts on this, but I spend a lot of time thinking about this, where in our profession, we know the statistics, we know the need, as you said. So we say, okay, we're going to offer this service. And then where are the people, right? So there's almost like a mismatch between the need and then the service, but the customers, if we're calling, right, the patients, the clients, the people, don't always connect. And so actually like how you've then switched to that hybrid schedule of outpatient scheduled appointments and same day access, that's repeated across a lot of settings that I've talked to. In order to keep up productivity, they've had to do that. So not sure if others have any experience with that.
We've done that. It took, we were integrated into OBGYN, and they certainly referred all of our positive PHQ-9s and EPDSs to us, but it took 18 months to get an actual referral back from someone who wasn't clearly distressed. Like it took 18 months for someone to say, hey, this patient has a history of depression. She's doing great now, but I wonder if you might want to chat with her because she's at increased risk postpartum. It took a long time. And we did our own chart review. We reached out to providers. And now, 5 years later, we get so many, but it was surprising, right? They want this, they want this. And then here we are. And I think they're not sure how to use us sometimes.
Dr. Ashby, can you expand on that a little bit? So after 18, so what were you doing to get that? Yeah, well, yeah, not to, no, I don't mean, what were you doing in the 18 months, but how do you think that you helped them start to refer?
Yeah.
You said chart reviews, yeah.
So I think, at least in our setting, our medical provider's view was if someone wants therapy, this is when I make a referral. This is when I get integrated care. And there's not necessarily a lot of patients enough to fill our schedules that are saying, I would like therapy. Yes, I would like to meet them today. And so by scrubbing charts, by saying, hey, provider, we give a summary to them. Hey, hey, provider, this patient actually had a fetal loss 5 years ago. It looks like she's pregnant again for the first time. I'm wondering if she might have increased anxiety or depression. What do you think about my meeting with her today at your visit? And so giving them some information about here's why we think we might want to see your patient was really helpful to them to start making connections about, oh, now I have another patient like this. I wonder if our team is called Promise, if the Promise team could see this patient. So I think it took a lot of that initial kind of 2 sentences of why that really helped them start to make the connection of it's not just, do I have a patient in front of me who's willing to engage in therapy or mid-management? It's, these are the risk factors that our mental health team is looking for. And this patient meets these, falls into that risk factor. So therefore, now I understand how to use the service.
Wow, that's very sophisticated. And so the onus is not necessarily on the provider to remember or the patient to say, I need therapy, I want to talk to somebody. It's your team kind of preemptively coming up with those lists or people they should tag.
And then we actually get a list generated from Epic of all the patients we've seen before that are coming in today.
Yes.
So then we can keep reaching out to providers and say, hey, we saw this patient last time. Would they like us to meet with them again? So I think that also helps. Like you're saying, the onus is not on the provider.
Because they're already managing so many things. That's
Yeah.
great. Thank you. Diana, did you want to jump in?
Yes, but I'm trying to click all my buttons. Sorry. I guess I just wanted to say that this year has really presented kind of a move for me into more state associated grant kinds of things, like once you're established as somebody who knows something about this or is interested in, which I am passionate about, as Helen knows. But so I've been faculty for this ECHO series on maternal mental health and just got asked to do the 3rd year of that. And they're doing some perinatal mental health focus groups, really looking at women who are marginalized and so I used to chair the Maine Migrant, now Maine Mobile Health Program Board, and I'm really passionate about that. So, I mean, it's helpful knowing the Primary Care Association and knowing the FQHCs could hook them up with finding the women that they're looking for. And there's a psychiatrist who's coordinating that, and I'm working with her on that. And they're doing a presentation with Dr. Nancy Ruddy in the fall with Maine Families that does intervention with families, and they're looking at wanting information about screeners. And then last Friday, there's the state meeting that I had not seen before, but it was on maternal mental health. And I went, and I'll tell you, those women, I just wish I had the pictures of all the women and what they were doing. It was just unbelievable, really, really exciting meeting, but it was very interdisciplinary. And anyway, there's a lot of energy in Maine right now for maternal mental health.
And Dr. Prescott, I'm so happy that you've mentioned the kind of our role at the state level and the federal level. There's overwhelming need for focused expertise and advocacy in policies and legislation and funding. And thank you for your work. And I always want to say ditto across the country, because there's so much work that we can do. I want to come back to Dr. Ashby's comment for a second. I loved what you shared about the role of the behavioral health provider in an OB setting to bring to the attention to a provider that a patient may be at risk, or they're already been seen, would they like to have continuity? And I want to invite everybody, because some of you are doing program development, not just in obstetric settings, in outpatient or inpatient obstetrical settings, but the continuum of women's health settings. And I love your model because we repeatedly see a failure to see, and I'll try not to get on my high horse here. We're not doing a good job preventing or minimizing risk of adverse outcomes, whether they're biomedical, whether they're mental health, whether they're psychosocial, whether they're financial. We can do better. And I love the promise model that you are proactively saying, this is an individual at risk for adverse outcomes following a obstetrical trauma or a personal trauma. How many times do we see people I specialize in trauma-informed care and women's health. We see individuals who have an experience of IPV or sexual assault, or just lost a house from a fire, or whatever the example is, came back from combat, whatever the example, just lost a loved one. We can do better through proactive models to work collaboratively to say this is an individual at risk for any number of adverse outcomes. Really would like to see this person. If you're a health psychologist, you know that our field started documenting the benefit of actively preparing people for procedures, improving both biomedical and psychosocial and mental health outcomes. Well, of course, that was in the 50s. We have enacted started in OB, proactively preparing people for persons for labor and delivery by a nurse, I might add. Of course, we can extrapolate that to 25 areas to dramatically improve women's health outcomes. So I just wanted to passionately, it's obviously one of my favorite areas to not only talk about, but to bring teams to do a better job, because we can really improve outcomes. And Dr. Ashby's team is doing a spectacular job. And I know some of you are so well positioned to use more of a preventive empowerment frame in integrated care. So I'll be quiet, but I couldn't miss the opportunity to build on her comment. Dr. Thomas, you have a comment we struggle with. Go for it.
I was just wondering on the not so great side of things, we still struggle with co-located care mindset with like drift. And we've been doing this 6+ years, but we'll go to the OBGYN provider huddles and, hear nursing comment like, oh, they're like, we have a therapist here now. And we're like, yes, but this person is now a part of your team, just as vital as the nurse and the MA, and just helping them get language around what that looks like, not just there's somebody down the hall that's gonna, we're gonna refer you off to. So I don't know if any of you have ever struggled with that, or if there's any tips. I feel like we're still building the plane while we fly it, of like helping them get in that mindset of this is a different way of thinking about your practice rather than just referring out. I don't know, anybody else having any drift or challenges there with good intention. I think our behavior is coming from specialty care. There's that culture too, right? Of like, oh, now you're part of a medical team. So it's challenging.
Dr. Thomas, can you talk a little more about what you would prefer them to, like what the preferred mindset would be, or what their behavior would be different, or how it would be different?
I mean, I think even if, I guess we struggle a lot too with like episode of care, especially in the guy, not, I mean, being pregnant, I think has its own kind of bookends on it, but we have a very resource limited community nonprofit health system. So I don't know if we have higher acuity than the average bear, but we're rural. So we find like, we'll load up our COCM caseloads and then often like, okay, how do we offload these folks? Like, what is the goals? You know, what is the offboarding plan? Because we have, instead of uptake, like, oh, we don't have enough referrals, we have the opposite problem. We have too many referrals, and our behaviorist is like, hey, I'm full. And, you know, don't let AIM Center hear me say that, because they trained us that like, oh, that's not integration. But that's our drift, right? Like in our real world setting, we have a lot of appetite for behavioral health support, but only so many slots for a behavioral health care manager. So sometimes we struggle with just, you know, model fidelity, and are we doing it right? I don't know, just sharing.
One of the things, because we have that too, because I think sometimes for providers, it's faster to say, oh, there's a therapist down the hall, they can schedule with you, and they just go on to their next thing. And often, right, it's hard to get people back on the phone. So we use Epic Chat. It's what our OBs prefer. And so I have our team chat them back and say, oh, you know, yes, I'll reach out to her. And I called her and she didn't answer the phone. Next time they're here, I'll meet with them in clinic. And so I have them keep saying like, oh, I missed them on the phone. Hope they call back. But next time, this is what we want. And it seems to help. I mean, it's one person at a time, right? That it helps, but it seems to help address that. But it for sure happens when we get new residents. Everything moves again. So I think having a way to say, or we say, oh, I can't get them in for a month, but if they're coming back next week, I can see them next week while they're here. So some of those kinds of things have been helpful to us, but I think the drift part is hard.
It's kind of hard to not, you kind of want to build and build and build, but we can't really be everything to every program in primary and specialty women's health settings. So I do think it takes some prioritization, because once you get the champions to realize how valuable and impactful the work is that we do in integrated models, irrespective of your model, and hopefully combined models, then you're going to get more and more requests at a time when practices and systems are going to be challenged. And so I think it does, I suspect that this group may want to have an additional conversation in October or November, after we see what budgets look like, because of any number of local, state, and federal challenges and changes. It's an opportunity not to shut down, but to be more innovative and more collaborative. I don't have it in arm's reach, but I have this little sign that says, think out of the box. If there ever is a time to think about leadership in integration in women's health and mental health, integration in women's primary care and specialty care, this is a time to think out of the box creatively, and to think about, in your leadership roles, what it means to lead your programs in a time of uncertainty, to sustain the vital programs that you already have and want to sustain, or you want to build. The answer is, I don't know, we'll just wait and see. That's not an answer. The stakes are too high. So on behalf of the populations that we serve. So I will be happy to make myself available anytime, but I have a hunch that we're going to be facing some complex leadership challenges in the months ahead. And I want to invite everybody to use their skills and passion and collaborative and relational skills and science skills to think out of the box. Dr. Ashby and Dr. Thomas, or any of you, might want to build on that, but I'm pretty sure it's not a time to shut down.
I have something just to kind of follow up on that. I love that, Dr. Coons. Thank you. And I agree. Can you share, to put you on the spot, I think, in times of chaos and crisis, what I'm hearing is our teams are getting frightened and they don't have a lot of room for creativity or new programs. They're scared to start new things right now. But I agree with you that we can't just wait and see. So is there anything like 1 to 2 things, tactical things, if we weren't going to wait and see, what would you recommend doing instead?
It's a very good question, and you just watched me demonstrate the first thing I would do. Pause. We are all running, sprinting, and that's not going to help right now. The pressure to work on all of all of you as individuals and as teams and as leaders is overwhelming. So one is to breathe and say to everybody around you, find space, make space, take time to step back. What are the most important parts of your programs? What is the most secure part of your collaboration and your funding? So one, pause. Number two, management and leadership are different. I know over many, many decades, I spent too much time managing and not leading, and I reflect back of missing critical points. This was a critical point to pause, think about where you are in your program, think about a strategic meeting, even in the context of uncertainty. You don't have a lot of details about your budget quite yet, although it's almost, for academic medicine, it's almost July 1. You do know a lot about your budget for 26, but many of you don't. So sit down and have a strategic planning meeting. Look at your sources of revenue. What are you not billing for? Not just where are you having losses, but where are you having opportunity for growth? Are there innovations that you could add that are not insurance dependent or Medicaid dependent? Do you need to diversify who you care for? Do you need to partner in different ways than you never have? Do you need to do some, and I'm thinking about, I haven't thought about this critically in an apropos of specifically women's health, but getting asked a lot about these questions. Do you need to partner in different ways? Are there places to collaborate and staff share that would be actually very helpful, where somebody does have funding and could cover one of your individuals, or vice versa? Do you need to sit down and talk with your program officers if you have outside funding about what they know? Unfortunately, many of them are functioning with as much uncertainty as the rest of us, but some of them have more information right now. So building, not letting those, not back to Dr. Ashby's vital point in clinical care, not being a passive, well, we'll see what they tell us, reaching out. What do we know? What do we not know? What's the timeline for decisions? So I want to stop there. I could kind of go on for a while. I don't think that's helpful. Maybe some of my our colleagues have some other reflections on how they're leading during times of uncertainty. Although I will say one more thing, supporting your teams. Everybody's very anxious, pausing, finding ways to say, everybody leave an hour early today, or who wants to go for a walk at lunch, or hey, how is your mother-in-law? How did surgery go? How are you doing with uncertainty? There was a very interesting article in the Harvard Business Review about, I think it was during the middle of COVID, about what senior executives were doing with teams of big financial companies. And I was very impressed with how many of them said, I'm sitting down with my team and saying, how are you? Not just bye, see you later, but listening, without it becoming a therapy session. But your team's feeling deeply supported. But what do other people think? That was the world according to me.
Yeah,
Do you agree, disagree?
yeah,
Have other
yeah,
ideas?
yeah, definitely agree. I was just going to share that, in these, upside down times, it's nice to see our bigger umbrella associations. I don't know if you guys, like on the medical side, a lot of us are AMA members or ACOG or AAFP. Like, it's nice to see those national associations use their voice. They have a lot of influence and, name recognition of like, hey, we as a society are pushing back against, Medicaid cuts, or we think, firing all 17 AKIP immunization advisory council members may not be the most evidence-based, scientifically sound things, and that someone's speaking up with that. I don't know, and then getting political, but like, it just feels nice to have some alignment in these tough times with our bigger peers and allies, just to kind of say, who are we as a group? What are we hoping to do for our patients, and make our voices heard?
And I think too, I would add, just like I think we do with the people we work with, the saying, today we have the funding and today we can do really good work. And what's that going to look like today? And I think holding both the immediate and the future, I think is hard. It's hard for us to do. And so I think being able to do both things and reminding people that even though we don't know what next week looks like or next month, we do know today. Because I think it's easy to sort of discount the work today because we're so worried about what's happening, what's coming, and being reminded of what we can do right now is really important, along with self-care and taking care of our teams and making sure seeing our larger, national societies and their work and how they're working in these policy kinds of ways.
I love that. That is all very helpful and insightful. I think, not panicking. At this point, I think we've done the gamut of panic and not, right? At least I have. But being proactive, looking at your sources of funding and income. If we hope these cuts don't happen. If they do, what might we do? I think being really realistic and planning as best as you can, as Dr. Coons was saying, is very helpful. And of course, then supporting your teams, which I'm sure all of us have been doing for a while now, and advocacy in ways that we can. So we have covered a lot today. If anyone has anything else, we have a few minutes left for any other burning questions or thoughts that people had. We have three women's health experts on the call.
I think I'm frozen, maybe.
Oh, I heard someone. Did anyone else hear that?
Yeah, Cheryl, was that you?
Yeah, can you all hear me now?
Yeah,
Yeah.
we can.
Okay.
Yeah.
So this is my first time to attend this. I'm coming from a different place in that I'm an educator. I'm a faculty member at Antioch, Seattle, and I'm a director of clinical training for a doctoral program. And I teach the primary care behavioral health class, and I place my students in pre-internships, internships, and a lot of our students do postdocs in primary care. I'm also an RN and did 10 years of work in labor and delivery years ago and have an interest in pre and perinatal psychology. Here's my question for all of you, and I'd like to contact some of you afterwards. I'm putting together a pre and perinatal wellness and health promotion interventions toolkits for BHCs and health professionals. And part of the idea would be, and this might be pretty idealistic, but part of the idea would be to look at more health promotion approach in BHC and OB settings, and where BHCs would actually be a part of prenatal care from beginning to end. And we're putting together some basic handouts, for example, on things like developing a relationship with the baby prenatally, creating positive babyhood experiences, in response to adverse childhood experiences, by the way, that kind of the idea that there can be adverse babyhood and prenatal experiences that also contribute to birth trauma. Difficult birth experiences and birth trauma, handouts early on for those that have those kind of experiences, things that they can be doing, treating mental health conditions in pregnancy, nurturing the baby's brain based on brain research, and psychologically, emotionally focused birth plans. And creating 2 layers of support. Anyway, healthy things that they can be doing during their pregnancy that will hopefully help prevent birth trauma. One of the members of our team is a physician that specializes in perinatal trauma and birth trauma. Veronique Mead, she also specializes in chronic illness. Anyway, I'd be interested in your thoughts on something like that. And maybe I can contact some of you offline if you have interest.
Happy to anytime. And there's really good models nationally, so you don't have to reinvent the wheel, although you are obviously very well trained to do this, and it sounds very exciting.
I'd like to become more acquainted with some of those things too. Yeah, thank you.
Sure.
Great. Cheryl, thank you. That sounds amazing. And it sounds like you are going to connect with some of the folks on this call afterward for maybe some ideas on content and how you might roll that out. That sounds great.
I just want to make.
Go ahead.
No, I just want to, we didn't go into policy development. Dr. Prescott mentioned a little bit, but this is a time to be very proactive. So please do write your congressmen and women or persons about any of the issues that are dear to your heart and to your patient population. And please do respond to your association requests for action items. They do make a difference. And so don't think that it's like, oh, well, someone else will do it, I don't have to. Please do that, and please edit them related to what you do, and provide stories and be prepared to provide stories to Congress people about if the potential impact of changes in funding on your ability to deliver services. That is something that's proactively we all can do, and it can make a difference. Not a time to sit back and watch.
Right. Great. Thank you so much to Dr. Ashby, Dr. Coons, Dr. Thomas, and all of you for participating today. We've covered a lot. Thank you so much for your interest and in joining us today. I hope that you have a good rest of your day and you join us for the next community conversation, and have a good rest of your day. Thanks so much.
Thanks, Stacy.
Thank you.